Good evening, ladies and gentlemen, graduates. Nice to see you all again here tonight. What a pleasure. Hippocrates, a long time ago, wrote that life is short, the art long, opportunity fleeting, experience treacherous, judgment difficult. What a lot of people don't realize is he wasn't talking about medicine then, he was talking about being a parent. No, he was talking, I'm sorry. He was talking about medicine, but it feels like that to be a parent too, doesn't it? It just feels like that to be a human being, I think. Remember, when we're talking about health policy, there are really three things that sort of funnel in to what we decide to do as a people. Our knowledge base, which medicine and medical institutions like the UW are so important in. So our social strategy, or what the average American thinks and believes and how they vote and how they behave, and our political will of our elected leaders. And all of that funnels in to what we call public policy. You all have a say in that. We all have a say in that. I think we need to speak louder than we have in times past. A lot of you have sent emails in about how much you've enjoyed the anatomy lab, and I think I gave this reference to last year's mini-med, but this is a magnificent book. It's called First Cut, A Season in the Human Anatomy Lab. It's written by a humanist who spent a year with the medical students at Emory University. And if you want to get a feeling for living and breathing in the anatomy lab, not so much the formaldehyde, but living and breathing in the anatomy lab, it's really one of the best books I've ever read. You can share in the experience of our medical students. And before I introduce Dr. Ramsey, I just want to read the poem for tonight. This poem is from Dr. Mary Bretcher, and she is from Springfield Clinic, Springfield, Illinois, and it's called The Process of Becoming. And if you thought about it, physicians are always in the process of becoming. We are always practicing medicine. But I think human beings are also always in the process of becoming. So, works in progress. We are gradually transformed as the wonders and energy and pains of others seep into the cracks we never thought were there. And like water in winter, freezing and thawing, imperceptibly but inevitably loosen our moorings, carrying away a piece of us as they leave in the spring. They leave in place a fine, soft powder to smooth our jagged edges, or a gleaming spark of emerald to make us sing, or the exquisitely perfect skeleton of a leaf, a gift of fragile beauty to grace our days, so that the defects left within us, and I don't know of a physician who doesn't have defects, by the passing of others are filled with a precious piece of them, to become entwined in our deepest, safest places, giving back more than they took away, remaking us anew. Ladies and gentlemen, before our evening really gets started, I'd like to introduce the Dean of the University of Washington School of Medicine, Dr. Paul Ramsey. This marvelous man was my advisor when I was a senior medical student. He was my attending in medicine clinic when I was an internal medicine resident, and he's still relatively sane after that experience. But more than that, he truly is a gentleman who's not only a gifted doctor, but a marvelous leader at a time when it's painful to be a leader of a major medical institution in the United States. And he leads with grace, with dignity, and with the utmost of professionalism. So please welcome Dr. Ramsey.
Good evening, everyone. The soon-to-be graduates, the 2006 graduates of the Mini Medical School. I'm here this evening to congratulate you, to thank you for your support, to thank you for your hard work. I assume there's been some hard work as part of being Mini Med School students. Is that true? And the tests are going to be harder tonight, but I really want to thank you for your support and for being here and for learning about what we do, for learning about our mission, for learning about what our core values are, and a bit about some of the approaches and the technology that we use that are so exciting in medicine in the 21st century. I'm here also tonight to say thank you to our faculty. We are really blessed at UW-Medicine, at our university in general, and within UW-Medicine, we have more than 1,900 full-time faculty. And those faculty work as hard as anyone I know around the world. They work very hard in their patient care. They work very hard with the privilege of teaching and doing research. These faculty not only work during the day, but they come here at night and do the mini medical school and a variety of other community service activities. So tonight I want to thank all of the faculty who have participated in this year's mini medical school and the many other community service events. And I'm also here to evaluate my good friend Terry Mengert and Norm Beauchamp. I have had the privilege of knowing Terry since he was, about this tall. He grew substantially as he became one of the best teachers on our faculty. But I need your help in evaluating them. How have they done in leading this mini medical school? Well, I think on the applause meter, that's a very good grade. I assume you weren't applauding for their humor. I assume it was all the medical content of what you've learned over the course of the mini medical school. So I really do want to thank all of the faculty and especially thank Drs. Norm Beauchamp and Terry Mengert for their leadership in putting the mini medical school together, in being here, and for their approach. I think that both of these individuals are models of professionalism, including the use of humor in medicine, which has a bit of a healing effect, as I think the newspapers recently published just in this past week. So congratulations and thank you very much. And for the Mengert family and the Beauchamp family, I have something to go home tonight, some flowers to celebrate.
Thanks, Paul.
Thank you.
Thanks, Dr. Ramsey. And thank you guys. Your checks are in the mail. Hey, tonight, very exciting topic, bloodless surgery coming of age. I'd like to introduce you to Dr. Andrews. Dr. Andrews received his medical doctor degree from the University of California, San Diego, his residency at the UCLA Medical Center, his fellowship at the very famous Johns Hopkins Medical Center, and he came to the University of Washington, fortunately for all of us, in 2003. And his interests are many, including non-surgical interventional radiology. Would you guys please welcome Dr. Andrews?
Thank you. Well, I'd like to thank Dr. Beauchamp and Dr. Mengert for inviting me here today to speak to you and give me an opportunity to talk about my favorite subject, at least my favorite subject in medicine. I think interventional radiology is a topic that people know very little about. In fact, most people think that it's actually international radiology. For a long time, my mother-in-law thought I traveled around the world fixing radios. And it's taken me a long time to clarify what we actually do. But I have the chance here to come and explain it to a new group of people. It really is surgery of the 21st century. And just to give you a little bit of a background, interventional radiology is actually a subspecialty of diagnostic radiology. A lot of people think that we do cancer therapy, like radiation therapists do, and there are some overlaps, which I'll talk about in a minute. I'll talk about some of the cancer treatments that we do. But there are some major differences there. Radiation therapy uses external energy sources to treat cancer, whereas interventional radiology works internally. It's sort of like internal surgery, working on blood vessels and other structures to fix them with image guidance and with only minimal incisions, small little incisions. What types of things do we do? Well, we do angioplasty. Most people are familiar with angioplasty, using balloons and small stents to hold open blocked vessels or intestines or kidneys, various things that should have channels and don't for whatever reason. We can also fix blood vessels that are open but are dilated and enlarged and at risk of rupturing using stent grafts. We do embolization, which is a technique that employs little particles injected through blood vessels to block the flow to tumors, to areas of bleeding from trauma, and ulcers and other bleeding diseases. We can block blood flow in the saphenous vein and treat vein disease. This is replacing vein stripping, which a lot of people are familiar with, but it does it in a way that involves no sutures at all. And patients get up off of our procedure table and walk out the door and go home the same day. We also do a lot of treatment of cancers, as I'll talk about later, but again, working from the inside with image guidance rather than from the outside with radiation beams. So how is IR different from surgery? Well, traditionally, surgery has used large incisions, sterile fields, general anesthesia, large working areas. The procedures that we do in interventional radiology, while they do use a sterile field, tend to involve very small incisions, a puncture that frequently doesn't require a scalpel to make, and almost never requires stitches at the end of the procedure. We very rarely need to use anesthesia for our procedures because they are generally not very painful. And yet they replace some of these major surgical procedures that people have been exposed to in the past. And as I said earlier, most patients are able to get up off of the procedure table the same day and go home. Very uncommon for us to need to use anything more than a Band-Aid and an aspirin to treat patients after their IR procedures. How is it different from the rest of radiology? Well, radiology is a huge field that has a tremendous amount of growth, very dynamic field that I'm sure that you've heard about in various facets throughout this mini medical school. But those things are mostly dedicated to diagnosis. And what we do with interventional radiology is to use those same modalities, ultrasound, MRI, CT, but to use them to target therapies. We actually admit patients to the hospital like other clinicians, and we routinely order imaging studies and basically have a large group of patients that we follow who are our own patients, like surgeons would do. Interventional radiology requires the full 4 years of medical school, then a year of internship, 4 years of training in diagnostic radiology, and then 1 or 2 years of fellowship after that. And then there are some board certifications that people get. So it's a fairly long course of training, but I think it's really worth it. And I think you'll see as we go along here this evening that there's some really exciting things that we're able to do with this training. I think before we go too far into this, let me point out that a lot of this started right here in the Northwest. The first angioplasty ever performed was done in the Northwest by Charles Dotter, who in 1964 opened the first, or was the first to open a blocked artery using interventional techniques. And he was able to help a woman who otherwise would have had an amputation keep her foot. Dr. Dotter was nominated for a Nobel Prize for this. He didn't win, not yet anyway. But it really changed our approach to medicine. And one of his most famous quotes is here at the bottom, where he said, "The angiographic catheter can be more than a tool for passive diagnosis and observation. Used with imagination, it can become an important surgical instrument." And that's what I'm going to talk about for the rest of my time this evening. So let's go back to angioplasty. Again, a lot of people are familiar with angioplasty. What you may not realize is how common peripheral vascular disease is. 20% of people over the age of 75 have some element of peripheral vascular disease. And for a lot of those people, the most common manifestation is crampy pain when they walk or exercise. That's not normal. It's not a normal part of aging. It can mean that there is a treatable vascular disease. Patients who have blockages and who aren't treated promptly have a fairly high risk of needing amputations, which is obviously a pretty debilitating outcome. Over 100,000 patients require, historically, surgical interventions in the United States to treat these conditions and to prevent amputations. Well, we're able now to fix a lot of those problems just using a balloon that we can introduce through a small puncture. These balloons go in through a hole about as big around as the point of a pencil. And once they're in place, they're inflated and they can open up blockages in an artery. A lot of times, just the balloon itself is enough to fix the problem. And if that doesn't fix the problem, then we can put in little devices. I'll show you a picture here in a minute. Little metal scaffolds that hold the vessel open and can maintain flow even when the balloon itself has failed. These are the tools that we use for stenting, for holding open blockages that don't respond to balloons. And you can see that on the left side of the screen here, there are devices that open automatically. As you release them from their device, they just pop open spontaneously. There are also devices that are mounted on balloons that we put into place, and when we expand the balloon, it opens the device, and then when the balloon comes down, the device stays expanded. Now, let me just say that a lot of people probably are thinking angioplasty is something that cardiologists do, and that's true, they do. And so do some vascular surgeons. And in fact, one of the things that we have here that's kind of unique within the country, actually, is vascular surgeons, cardiologists, and interventional radiologists all working together doing endovascular therapy with balloons and stents to treat patients from all different areas of our community. So we have the opportunity to involve a group of specialists with a lot of different backgrounds, a lot of different expertise in their training to do this one particular type of therapy, and it really is unique. This is just an example of a patient who could benefit from an endovascular procedure. Now, this is an X-ray angiogram of the aorta, which is the main vessel in the abdomen. You can see the aorta coming down here, and then right at the point where it branches into the arteries that go into the two legs, you can see that there's a very tight narrowing. And that narrowing extends all the way down into this artery, which is actually going to the patient's left leg. This image is presented as if the patient is looking at you. So this is the left leg with the narrowing. Now, this patient was treated. This patient was having severe pain in his leg whenever he walked. He also had problems with impotence and pain in his buttocks, all from blockages of blood vessels. And what we did was to put in some stents. And I don't know how well this projects, but you can see that there's a stent here in the lower part of the aorta, and then a stent going into each artery here in the pelvis. And these are before and after pictures of the same patient. Now, this is actually a complete cure for this person who, at the end of this procedure, has a Band-Aid on both groins and can walk out the door and go home. No anesthesia, nothing more than just a little bit of sedation to help him feel comfortable and relaxed during the procedure. And this is not a particularly dramatic example. I mean, this is what we do. This is what we see on a regular basis. This is another example. Now, we're looking at this person's aorta from the side. And this is a patient who has severe pain in his abdomen whenever he eats. And that's caused by blockages in the blood vessels that go to the intestine. So this is called the celiac artery. This goes to the stomach, the liver, and the spleen. And then down here is supposed to be another artery called the superior mesenteric artery that supplies the intestine. And it's not visualized at all. This is the same patient after a stent has been placed in the superior mesenteric artery, and angioplasty was performed without a stent in the celiac artery. So again, this is a cure for this patient. The alternative would be a pretty major operation where a bypass graft would be attached from the groin all the way up under the intestine in the abdomen and sewn in to this area here. Major operation with a lot of morbidity, very long recovery time. And this, what I'm showing you here, is something that can be accomplished in about half an hour, 45 minutes. And again, the patient walks out the door. Now, what I'm going to show you next is one of the more exciting applications of stenting. You may have read about this, treating carotid arteries with stents. Historically, a carotid artery was fixed by making incisions in the neck and dissecting the artery out, which can be dangerous because there are a lot of other nerves and important vessels in the area. It's a fairly long procedure, and a lot of patients wind up being observed in intensive care settings afterwards to watch for strokes and things. We're now able to fix this particular problem with stents as well. And I borrowed this video from Guidant, who makes one of several devices currently available for this procedure. So hopefully this will play. Starts off with an overview of a patient showing you the neck. Here's the carotid artery. Here's a device being introduced. And what you're seeing here is a very interesting concept. Now, there is a potential for small amounts of clot or plaque to be knocked loose when you're doing interventions in arteries. And obviously, you don't want those little particles to go to the brain. So what this system uses is a little tiny net here that's put into the artery. Blood can flow through the net, but nothing else can. So we put that device in first, and then do an angioplasty to open up the blockage, which is shown here. So there's a balloon going up, and now as this balloon is let down, you may, hopefully the resolution will allow you to see this, some little particles break loose and flow up and are caught in that net. The next step is to put in the stent. So here's the stent that's now been deployed. You see that it's still got a little bit of narrowing here. So after this, we put in a balloon. And the balloon opens the stent all the way. And now you'll see again, as the balloon comes down, some small little particles are released. But they're captured again in that net. And now the net is retrieved along with all the particles that are in it. So this is a procedure that can be done again in about 45 minutes, half an hour, something like that. These patients are awake. They can talk as we're doing the procedure. If there's any problem, we can communicate with them about what's going on. If they have any symptoms, we know it immediately. So it really is a huge advance, and the safety is improved, and the recovery times are, again, hard to measure because as soon as the procedure is over, the patient can get up and walk out the door. Here's a couple of examples. Here's a carotid stenosis, with a little arrow, a little circle around it. There's before, here's afterwards, and you can sort of see the stent here. Another example, you can see a very tight stenosis in this internal carotid artery, and here it is with a stent in place. Very typical results. Let me move on to another topic, stent grafting. Well, as I said, there are situations in which an artery is open, and in fact, maybe it's too open. Sometimes arteries can weaken and bulge like a bicycle tire. You get a bulge on the side of a bicycle tire, and you know it can pop. Well, the same thing can happen with blood vessels. And when that happens, if an aneurysm actually enlarges to a point where it ruptures, it's frequently fatal. About 80% of people who have ruptures of aortic aneurysms will not survive. Historically, the treatment for a patient with an aortic aneurysm was to do a large operation that involved an incision starting just below the rib cage, going down into both groins, and you would replace the entire aorta with a tube of synthetic material. It was obviously a major operation. When these aneurysms involve the chest, the operation frequently involves putting a patient on a heart-lung bypass machine and then a large incision through the chest, in the front or in the side, depending on what's involved, what part of the aorta is involved. Major operations with quite a bit of morbidity, very long recovery times. Now we're able to do all of this through punctures in the groin, basically, that frequently do not require any external stitches. This is the type of device that we put in. Now this differs from the other stents that I showed you because it's got a covering, and it's pretty evident here. Here's a metallic portion that is supporting the graft material, and then there's graft material that's sewn onto the stent. Now I've borrowed a couple more videos here. This is a thoracic aortic graft. This is a device that's just been approved by the FDA, which is why I don't have a video of my own here. I'm borrowing the company's. This is brand new. Here's an aneurysm of the thoracic aorta. For reference, these are the arteries that go to the brain and to the arms. And here's an aneurysm. Now, if this aneurysm ruptures, the entire blood volume of the patient's body will bleed into the chest within a matter of a few minutes. Now we're seeing a guide wire being advanced through the area of the aneurysm, and then here is the stent graft device. And this device is basically constrained in a manner very much like the little strip across the top of a dog food bag. And, you pull the string on that dog food bag, the whole top pops off. And you'll watch what happens here. As this string is pulled, the device deploys, and it's just that fast. Actually, it's a little faster than that. So what we now have is a covered tube that's supported entirely by this metal structure that springs open. No stitches. This is all held in place just by friction. But we've excluded this portion of the aorta that's weakened. And what happens is this whole aneurysm just collapses down and no longer represents a threat to the patient. Most aneurysms actually don't occur in the chest. Most of the aneurysms that we see in the aorta actually occur in the abdomen. That doesn't make them any less dangerous, but it's common enough that it's still nice for us to have an alternative to major surgery. This is an example of an abdominal aortic stent graft, and the interesting thing about these devices is we actually build them inside the patient's body. These devices are put in several different pieces, and we actually put one piece inside the other and construct them inside the patient. This schematic shows a large abdominal aortic aneurysm and the device already in place. Now I'm going to show you a video in a minute I'll show you a video of a device being put in. This is a CT angiogram showing an abdominal aortic aneurysm. So here's the arteries that go to the kidneys. Here's the artery, here are the arteries that go into the legs. And you see this large dilation here. This is a very dangerous situation, as I said. This can rupture and cause the patient to pass away very quickly. This is the same patient after an aortic stent graft has been placed. You can see that aneurysm, that big sac, isn't filling anymore. And instead what you see, you can actually see some of the metal struts here on the CT scan. So here's the video of the device being put in. Again, I borrowed this from Gore because I was already on the phone with them asking to borrow the other video. So typical location, this is where they usually are located, just below the renal arteries, the ones going to the kidneys. So initially what we'll see is this device coming in from the patient's right leg. Remember now the patient is facing us. So we put in a guide wire. Over the guide wire, we put in what we call the main body of the stent. There's a little covering on it that's removed. And then we pull the ripcord. And what you see is basically a pair of pants with one long leg and one short leg. So this is half the device. Now we have to put in the rest of it. So what we do is come from the other side, have to get through this. That's kind of the tricky part. Find your way through that little short leg. And then we deposit the other limb of the graft. And now what we've done is to exclude this weakened part of the aneurysm, of the aorta, from the flow of blood. And what happens now is this aneurysm sac collapses down. And again, the approach to this involves a couple of incisions in the groin, maybe half an inch or so long, and no external sutures at all. Now, changing gears, talking about something other than arterial anatomy, we're going to talk about some venous anatomy. And this actually, I had a little segue to this because we were talking about alcohol problems earlier in the evening. Portal hypertension, that is abnormally high blood pressure in the vessels that flow into the liver, is a pretty common condition that you see in patients who have liver disease. And I'll show you a schematic diagram here in a minute of sort of how it works. But when the pressure goes up, patients can have buildups of fluid in the abdomen or the chest, or they can develop basically varicose veins of the esophagus. And when those varicose veins rupture, which they frequently do, patients can have massive bleeding and bleeding that's extensive enough that they can die from that. So historically what was done was to make an incision that started sort of here in the middle of the chest and went all the way down, sort of like the old gallbladder incisions. And what you would do is actually put a little piece of conduit in there and connect the portal vein, which comes from the intestine going into the liver, to another vein that is capable of handling this increased blood flow and blood pressure. The problem is that in patients who are really sick, the mortality rate of that operation was around 50%. That means half the patients who had the surgery died during or immediately after the surgery. What we've got now is a procedure that allows us to do basically the same thing through a little puncture in the neck. And not wanting to beat a dead horse, but not being able to come up with another way of saying this, these patients get up off the table and go home. Now, here's my schematic. This represents the liver, this sort of triangular structure, and what's coming in from below is called the portal vein. So the intestine, all of the blood flow from the intestine drains into the portal vein and then percolates through the liver and comes out through the hepatic veins and goes to the heart. When there's a lot of disease in the liver and that blood can't flow through, what it has to do instead is find its way through other channels. So this vessel here becomes a big varicose vein that runs up along the stomach and the esophagus. And you can actually get other veins that enlarge and carry blood away and can lead to bleeding. So one of the treatments for this involves rerouting this blood flow so that instead of having to percolate through the blood, or trying unsuccessfully to percolate through the liver and going this way, it actually finds its way directly through a shunt into the liver, into the heart. So what we do is we come down through the neck with a long needle, and we puncture from this vein, again, which drains into the heart, into this vein, which is draining from the intestine. We use a balloon to create a little channel, and then put in a stent. And now what happens is the blood is able to flow this way through the stent and into the heart. So you see that this vein here that was enlarged and potentially bleeding goes back to its normal size, and the blood flow is restored to normal. And this is a procedure that takes about 45 minutes or so, and the perioperative mortality rate basically is 0. So it's an extremely successful method of handling this particular problem. Here's an example from an actual case. What we have here is a catheter that's coming down from an access site at the neck, going actually through the heart, which is here, and we've made a pass through the liver tissue into this portal vein, and we're doing an injection of some X-ray dye. So this configuration matches this drawing. And what we're seeing here is these massively enlarged veins that are along the stomach and going up into the esophagus and potentially bleeding. Now, this is the same patient a few minutes later after the stent has been deployed, and the blood flow is now going through this stent and back to the heart without having to go through all these channels. Another topic, uterine fibroids. Uterine fibroids are extremely common. About half of women in certain ethnic groups have uterine fibroids, and about half of those women have symptoms, which can include massive bleeding, compression of the intestine or the bladder, pain, and distension of the abdomen. About 200,000 women a year in this country have hysterectomies just for fibroid symptoms. But what we're finding is that if we occlude the blood flow that goes to the fibroids, we can eliminate the symptoms in 80% of women. And we can improve the symptoms in another 10% of women enough that they don't need any other treatment. And this is another one of these same-day procedures. I won't say that anymore. From now on, if something is not a same-day procedure, I'll point that out. These are the tools that we use for fibroid embolization, and I have a penny here just to give you an idea of how small these devices are. This is a catheter that's used for us to find our way into the artery that we need to treat. If that catheter is too big, we have this other catheter, this sort of light blue one here that can actually go inside the first catheter, and that one there in the middle, the light blue catheter, is less than 1 millimeter in diameter, so it's pretty tiny. In fact, we could make them smaller, but we wouldn't be able to see them anymore, so this is about the limit of the size. Then at the bottom here, sort of scattered over the penny, are these little tiny particles. I'll tell you, if you look at them under a microscope, they look like cornflakes. But what they do is they are carried by blood flow out into a vessel where they sort of pack up on top of each other and form a plug. And so what we can do is by injecting these particles, we can target a certain vessel, we can block the flow of blood through that vessel, and if it's a trauma patient, we stop the bleeding from a gunshot wound or a liver laceration. If it's a tumor, we stop the blood flow and help the tumor shrink away or make it easier to treat surgically. And if it's a fibroid, we basically kill the fibroid and it shrinks away along with the patient's symptoms. So here's a couple examples. This is a patient before and after fibroid embolization. And what we have here is a catheter that's been introduced through the artery in the groin. And we usually use that access site because the artery is close to the skin there. We actually can thread the catheter up into the aorta, down the other side, and into the artery here that goes to the fibroid. And everything that you're seeing here in the pelvis, all of these vessels are abnormal. Those are all arteries that go to fibroids. Here's the same patient a few minutes later after the particles have been injected, and that fibroid is no longer visible. It's no longer getting a blood supply. And so what happens, it's basically like taking a grape and plucking it off the vine. It just kind of shrivels up and becomes a raisin. Well, fibroids just kind of shrivel up and become little mummified remnants of themselves that no longer cause symptoms. Now, just to show you an example of how this can impact the patient and what kind of a result you get, this is a woman who was 32 years old and had chronic menometrorrhagia, which basically means bleeding that's heavy during periods and between periods. She had a severe bleed when she came to the emergency room and had a hematocrit of 17%. Normal is about 40, 45%. 20 is pretty critical. 17 is basically the patient disappears against the sheets because they're so pale. This woman had an MRI of her pelvis, and what we're seeing here, these are the hip bones. We're looking straight on to the patient. And this is her uterus, and it's filled with all of this material, which is all abnormal. And I'll show you an after here in a second. You'll get a feel for how much of this is actually abnormal tissue. This is a view of her from the side. So here's the cervix, and here's this uterus that's been distended by this fibroid. And for comparison, here's her urinary bladder. So this thing is basically filling her pelvis. It's probably about that big. So we did an embolization in this patient because she was too sick, basically, to have an operation. And this is what she looked like 4 months later. So these are the same magnification. Now, here is her uterus, here. And here it is from a side view. This is basically a completely normal uterus. Now, there's a little bit of increased signal here, which is a little bit unusual, but that'll fade, and she's basically got a completely normal uterus at this point. Now, I'll tell you, this is my best example. They don't always work out quite this well. Usually we wind up with a reduction in size of 60 to 70%. This woman basically is completely normal after embolization. So for her, again, complete cure. So, another topic, venous insufficiency. Historically, the treatment for patients with abnormal blood flow in the legs was vein stripping. And vein stripping involves putting a little plastic or metal rod into a vein that runs up and down the inside of the thigh. You tie a suture to the top end of this rod and then pull it out, and along with it comes the vein. You just sort of turn it inside out like pulling off a sock. It tears off all the branches that are connected to it. It's a very effective procedure. It's what got the Mayo brothers started, but it is unappealing to say the least. A lot of people put up with a lot of symptoms from varicose veins and abnormal blood flow in the legs rather than have this surgery. But we're now able to treat this procedure with a fully internal technique where we basically seal the vein closed using laser energy and do this through a puncture that is small enough that we don't need to use a scalpel to make an incision. So just as a schematic diagram here to help you understand what we're talking about, this is meant to represent veins in the leg. Normally what happens is that all the blood flow from the veins of the skin drains into the veins that run sort of just under the skin, and then using these little one-way valves that are represented here as these curved structures, the blood is directed either toward the head, like this in what's called the saphenous vein, or goes deep into deep veins inside the leg where the muscle squeezes and pumps blood. A lot of people think that blood goes back to the heart because the heart is pumping. And actually that's not true. The heart only pumps blood out. It's the muscles in the body that pump the blood back in. But that only works if these valves are intact. When the valves fail, what happens is blood can flow the wrong direction. So the blood gets pumped up by the muscles, and then it turns right around and goes back down the leg, through these abnormal channels, these bad valves. And so the purpose of vein stripping is to remove this whole segment here that allows the blood to flow backwards. And what we do now with the laser is to introduce it into that vein. You advance it up through the whole segment that needs to be treated, put in the little laser fiber and turn it on, and then as you pull the fiber back through the vein, while the laser is turned on, we basically just seal the vein closed. And so what happens after this procedure, which takes about half an hour, 45 minutes, put a compression stocking on the patient's leg, and they go home. Sorry, I told you I wouldn't do that anymore. It's hard not to. I can tell you that this technique works for a lot of different reasons. First of all, I've had it done myself, and I can tell you that it made a huge difference for me because I stand up all day, and before I had this, I really couldn't do it. I had to sit down partway through the day and put my leg up because it hurt so much. And I can tell you it works because I've treated a lot of patients. And believe it or not, this is actually the first patient that I ever treated with this technique. She was a 65, I believe, year-old ER physician. And if you look at her left leg, you can see all these varicose veins here, varicose veins going up her thigh. Her problem, like mine, and like a lot of people, was pain. I mean, it didn't look great, but the main problem is pain. So this is what her left leg looked like a couple of weeks after treatment. And all we did here was this vein ablation. We didn't do any other treatments. This is the other leg. You can see this big, large, ropey, varicose vein here. And what we did was not to treat that vein, but to treat the vein that supplied it, treat the vein that was flowing backwards into it. And this is what her other leg looked like after the procedure. It's not entirely without some side effects. You can see a little bit of bruising here. But basically, 45-minute procedure and you have a cure. And now, interestingly enough, this woman told me after her procedure was over that she was noticing that she no longer got dizzy when she stood up. Used to be that for years before this, when she would go from a lying down or sitting position to a standing position, she would get lightheaded for a second. And everybody's had that every once in a while. It happened for her all the time and went away after this. So at least theoretically, what was happening was that the blood was rushing to her feet away from her brain. And by doing this procedure, we at least modified that and helped her with that symptom as well. Well, moving on still to another topic. This is one that a lot of people may have heard about, vertebroplasty. And I'll also talk about another procedure called kyphoplasty. But basically, these are both treatments that are used to treat compression fractures of the spine. So as people get older and get osteoporotic, they can have fractures of the spine that causes pain and causes a loss of vertebral body height. And it's very difficult to treat. In fact, usually people don't treat it. Usually people say, well, just got to take some pain medication until the pain goes away, and it's in your genes. You should have had more milk when you were younger. A lot of good that does you when you're already having symptoms, but unfortunately, that's kind of been the way it goes. So this is just a kind of a dramatic example that I borrowed from the National Osteoporosis Foundation, showing the same woman 25 years apart. Classic sort of a configuration here with this, the compression fractures of her spine causing a loss of height and a collapse of the chest with compression of her chest and difficulty breathing. It's just sort of a vicious cycle that you get. The pain, the spinal deformity makes it hard to breathe, makes you more prone to infection. You have more time at bed rest. It just sort of spirals down further and further. And as you are less active and have more difficulty with eating, your bones get more osteoporotic. It's a vicious cycle. Vertebroplasty is a technique for fixing that. And basically what we do is using imaging guidance, we put a needle directly through the vertebral body from the back and inject some bone cement into the vertebral body to strengthen it. And most people who have this procedure report an immediate relief of pain. So this is something that's done when patients have acute compression fractures. A typical example would be somebody who has a minor fall or lifts something and suddenly has excruciating pain in the back, something way beyond what you would expect for the level of stress that they were under. And this would be in somebody who has underlying osteoporosis. And the vertebroplasty is done and immediately results in an improvement in symptoms and a relief of pain. So this is something that we can do on basically a moment's notice. Now, the most recent advance to that is kyphoplasty, which in addition to stabilizing a fracture, actually can improve some of that loss of vertebral height. So what you do with this procedure is, very similarly, put a needle into the vertebral body, but in this case, you actually use a balloon, which is shown here in figure C, to push that vertebral body back up and also create a larger space now for that bone cement to go into. Again, this is a procedure that's readily available and is used on a regular basis and has tremendous impact on a lot of patients. These are just some images that show the balloon in place and then the glue in the vertebral body. I'm going to change topics one more time. Oncology, cancer. Cancer is something that we see a lot of, unfortunately, still. There are a lot of great treatments that are available and new treatments being developed all the time, including some that are being developed right here at this institution. But for patients who don't have good solutions, we can do very targeted therapies now to treat cancer. So instead of having to have systemic chemotherapy with the side effects that go along with that, we can actually target just the tumor and do very specific therapies and by doing that reduce side effects that people get. So I'm going to talk about a couple of different things that we do, and then again we'll talk about the latest and greatest, which actually doesn't involve any incisions at all. I'm getting just kind of whet your appetites a little bit. Chemoembolization is probably the first technique in this category, and basically what we do is to identify the tumor that is feeding an artery. Identify an artery that's feeding a tumor, and then inject into that artery a mixture of chemotherapy and embolic material. So this is sort of like the fibroid embolization. We're using particles to block blood flow, but in addition to that, we're mixing in some chemotherapy. And what happens is we can deliver all of the dose into the tumor. So the same dose that would ordinarily be given into a vein and circulate through your whole body is now going straight into the tumor. So we can give much higher local doses than you would be able to get if you got it by vein. And then on top of that, we're blocking the blood flow so that this stuff can't wash out. I mean, it's there, it's trapped in the tumor and bathes the tumor, which also has now lost its blood supply, so its nutrients and its oxygenation are going to drop off. And it can have a very dramatic impact. So here's an example of a patient who's having an arteriogram. There's a catheter here. This is that celiac artery. We looked at it earlier in a patient. I showed you a side view before. Here's a catheter that's been introduced. Try to get my mouse here, my pointer. So here's the celiac artery. Here's the artery that goes to the liver. And out here, you see this initial blush of some abnormal vessels. And as the injection goes on, the contrast injection, you see a progressively darker and darker mass. So this is a pretty typical appearance of a patient with a tumor in the liver. This is what it looks like after chemoembolization has been performed. Now, you can't really see this very well, but here's one of those little tiny catheters that I showed you earlier. So this catheter is going way out there into this artery. This catheter is probably that far out beyond the aorta, going through little twists and turns. And because we can get it way out there, we can deliver this whole dose right to the tumor. And here's a CT scan of the same patient showing all of this area where the tumor was is now filled with this chemotherapy and the blocking agent. And yet the whole rest of the liver still has its normal blood supply. The interesting thing about tumors that go to the liver is that they're almost exclusively supplied by the artery to the tumor, to the liver, whereas the liver itself gets a significant amount of its blood supply from the portal vein that I showed you earlier. So when we do chemoembolization, we wind up having a very dramatic impact on the tumor and almost no impact on the liver itself, even though they're right next to each other. In fact, the tumor's in the liver. So it's a great procedure. And we do these, we probably do a couple of these procedures a week here at the university. Now, if you have a patient who for some reason can't get that, let's say the arteries are blocked already, or the tumor just doesn't have much of a blood supply to it, then we can still do treatments that are directed at the tumor, but instead of using the blood supply, we basically put a needle directly into the tumor and then supply heat, a high or very low level of heat. So in other words, we can either burn the tumor or freeze the tumor using a needle introduced through the skin. And this is an example. There's more than one system for doing this. This is one that Boston Scientific makes. And what you see here, this thing that kind of looks like an umbrella without a skin on it, is a probe that can be introduced closed. I mean, those tines are not exposed when you put it into the tumor. And then you expose the tines, and those tines create an electrical circuit within the tumor and generate enough heat that the tumor is destroyed. We do this with ultrasound or CT. Now, this is one where we usually do use some anesthesia because this can be painful enough that patients have a hard time having just sedation, although we can do it either way. We usually use anesthesia because patients prefer it. This is a schematic diagram showing some grounding pads on the thigh in blue. This is an electrical. We have to create an electrical current, so the thigh has a grounding pad on it. The probe in this particular case is in the liver, and what we do is just turn this device on and generate enough heat to kill the tumor. Sometimes tumors are big enough that we can't just do one treatment. We have to actually do one treatment and then move the device back a little bit and do another treatment, create a cylinder of heated tissue. But again, this can be as effective in treating tumors as actually removing that segment of the liver. I mean, we consider this to be curative of that particular tumor. Unfortunately, frequently patients will have more than one, but for each individual tumor that we can effectively target with this technique, we can be very successful in curing that tumor. Here's an example, ultrasound guidance of one of these procedures underway. Doesn't really show very well, but here's the needle that's been introduced into the liver, and here are these little tines that have been opened up. And as the energy is put into the tumor, you create this very echogenic, bright white area here that represents the tissue that's been destroyed. So you keep this energy going until the entire tumor has been destroyed. Here's a patient's CT scan after this procedure has been done. Unfortunately, I'm sorry, I forgot to put in the pre-procedure. If you imagine this same liver with this area here being bright white and kind of looking like this and representing living tumor. This is what it looks like after the patient's been treated. Now this can be used in other areas too. Here's an example of a patient with a large mass in his chest. Here's the heart, and here's the lung, and here's this large tumor with the tines exposed and the treatment underway. So this is a CT scan rather than the ultrasound that I showed you earlier. But we can treat tumors in the lung. We can treat tumors in the kidney. We can treat tumors in bone. This is a woman who had a metastatic sarcoma to her leg. This is an MRI. This is the tibia, which is the shin bone. And this bright area here is a metastatic tumor. And rather than do a big operation to remove this, what we did was to come in this way, just basically drill a little hole through the bone, put in this probe. You can see the tines. This is a slightly different design. The tines don't stick out quite as far. But this patient had this procedure done, and, well, you know the rest. So this is the end of my talk, and I'm going to show you one last slide here in a second, but what I want to point out to you is that these are minimally invasive procedures. They're commonly used, they're readily available, they're very successful, and we're continuing to develop new things all the time. The obvious next question is, can you make it even less invasive? Can you do it with no hole at all? And the answer to that is yes. And so I'm going to show you my last slide here, which is sort of a take on what interventional radiologists are, and let you think about how we maybe could do some of these things that I've just shown you without making any holes in the skin at all. Thank you.